Hey there, welcome to Resilience Radio. I'm Irvin Eisenberg, host of the show and owner of Resilience Occupational Therapy. As always, the opinions on this show are not necessarily shared by me, and I feature a variety of different perspectives. Additionally, none of it's meant to be medically diagnostic or prescriptive in any way. Today's guest is Dr. Mel Hauser. She's an MD, a board-certified family physician, and the executive director at All Brains Belong, Vermont. It's great to have you on today.
Thanks for having me. Great to be here.
So can you start off a little bit with telling us what led you to become a doctor to begin with?
Oh, sure. I think that I've always been drawn to people's stories, and I always appreciated the privilege of being invited into someone's world and learning about their worldview, and doing whatever I could to try to support people on their journey. And so I did a couple of other things before medicine, but it was always about forming connections, relationships, and entering into someone's world.
That's led you to your role as executive director of All Brains Belong. Can you tell us what led to All Brains Belong and what All Brains Belong is?
Definitely. So All Brains Belong is a nonprofit in Montpelier, providing neurodiversity affirming medical care in addition to social connection programs for kids and adults and educational trainings. And what I found when I worked in traditional primary care is I found that the 1 in 5 people whose brains learn, think, and or communicate differently than the so-called typical brain, even though I don't think that there's such a thing as a typical brain. But those people whose brains work in ways that significantly depart from the types of brains that society has deemed typical, those people were not getting their needs met. And I was spending so much of my time in the exam room trying to problem solve and help people problem solve life outside the exam room. People are lonely, hard to make friends, hard to access their education, hard to access employment or keep employment. So it just made no sense to me that to continue to practice healthcare in a way that was completely separate from the rest of life. So I quit my perfectly stable job and started this nonprofit organization last year with the idea of smushing and merging medical care with what I consider to be part of health, which is social connection, education, employment, all of these things, essentially all of the things that an individual person would consider part of their self-actualization.
Okay, and what does this look like in practice? What does All Brains Belong? Is it consisting of more than one practitioner, and what do those sessions look like?
So we have. So I would think about, like, we have 3 buckets. So we have healthcare, which is both primary care, and we see folks who have primary care relationships elsewhere but are looking for some additional support around brain, nervous system health, and some of the medical conditions more common for neurodivergent people. Then we have this bucket of social connection programs. We have a weekly program called Brain Club that's virtual, where we cover everyday brain life things. And this is, it's adults around the country coming together and forming social connections and learning and unlearning a lot of things together, plus social connection programs for kids based on shared interests. And then the educational training. So this is, going into organizations, healthcare organizations, and a range of organizations, actually, talking about things like what does it look like to be neuro-inclusive? What does it look like to create environments where people with all types of brains can thrive? So we're doing all of that. But to answer your question about what a healthcare visit looks like, I think the people who are getting the most out of their medical care experience here is it's people who want to be connected to other people. So these are patients who are looking to meet other patients, who are navigating similar health challenges. They're participating in these community programs, because it's really, we have found that connection is the path to health. So it's the model really is like a community village of learning and healing together.
Okay. And how many different practitioners? Are you the main primary care physician there?
Yeah, we have three clinicians here. So
Hmm.
it's myself, Sierra Miller is a nurse practitioner, and Gabe Borzella is another family doc, who also is has a fellowship trained in integrative medicine.
Okay. And they all bring their own experience with neurodiversity to the table, I
Yeah,
assume.
yeah.
So could you, I want to talk more about specifically All Burns Belong in a little bit, but could you speak a little bit to what do you mean when you say neurodivergent? How far divergent and how close to norms are we talking about?
Yeah, so again, when I use the term neurodivergent, I'm referring to again, this is a lot of people. This is at least 1 in 5 people whose brains work in ways that significantly depart from the bell curve, the ways in which society has deemed typical. But I really don't think that there's a typical brain, but society gives everyone that message. So I'd say that some neurodivergent people have specific diagnoses: autism, ADHD, dyslexia, dyspraxia, dyscalculia, but most do not. Many of the people who come here, they come here because their needs were not met by the traditional healthcare system. They didn't come necessarily knowing that they're autistic, for example. They came because they're struggling and they're looking for some support.
So without obviously divulging too much personal information about any clients, can you give an example of types of support that were lacking in the mainstream system that you were able to fill?
What we are seeing is that amongst a population of neurodivergent adults whose needs were not met by the traditional healthcare system, there are some medical conditions that they have in common. We are seeing, for example, the trend toward connective tissue differences, including hypermobility spectrum conditions, including hypermobile Ehlers-Danlos, and related conditions like POTS and dysautonomia, mast cell dysfunction, chronic fatigue syndrome, fibromyalgia. There's this host of conditions that really run together and appear to be all one cluster,
Mm-hmm.
that are more common for neurodivergent people. And which does make sense because these are neuroimmune conditions. And so if people have autonomic nervous system or immune patterns that are dysregulated, and there is a lot in the environment that dysregulates people. And people internalize this narrative that there's something broken about them, when really it's that the environment is a mismatch for their needs. And after decades of living in a world where your access needs are not met, this has a profoundly negative impact on health.
Okay. Could you give like a hypothetical example of what that could look like?
Yeah. So it's not uncommon that people come here and they are reporting chronic pain that has for which an explanation has not been given. They're also, maybe they're struggling with their sleep. They're struggling with their attention. They're struggling with they're grinding their teeth at night. They're having issues with their gastrointestinal tract, and in a traditional system where a 15-minute visit focusing on, one or two symptoms at a time, it's like Google Maps, where you're so zoomed in, you don't know what continent you're on. You have to zoom way out in order to name the thing. That these things are all connected, and they're connected through the neuroimmune connections of the nervous system and immune system.
Okay. So I'm quite fascinated by this, because I think there's a constellation. There's a lot of clients I have that fit this constellation of symptoms.
Of course.
These are not uncommon things, and it seems I think the 1 in 5 number seems a bit low.
Definitely.
From what you're saying. Yeah. So sleep, chronic pain and GI stuff, and attention is in there as well, are all things that seem to be pretty inherently linked to each other. And with some of my study with pain neuroscience, that it's a hypersensitivity in the system.
Yes. Yes.
Or dysregulation seems like goes hand in hand with that.
Yes, absolutely. That's what this is. So if you have a hypersensitivity to input coming into your nervous system, you are more likely to be dysregulated by it. I myself am autistic, ADHD, dyslexic, dyspraxic, dyscalculic, and I have many of these connective tissue / neuroimmune challenges that I didn't know were connected. I didn't know they were connected. And now we have, almost 300 patients who also didn't know they were connected. And that's where this community village model really evolved. These are people who are coming together to learn from one another.
Mm-hmm.
And what we're seeing is that they're getting better. They're feeling better. Because we're elevating the wisdom of people with lived experience. So this cluster, by the way, also includes long COVID.
Mm-hmm.
So we know that, there's literature that neurodivergent people are more likely to get long COVID. Higher rates of long COVID in this community. So it would make sense that we would see more long COVID than, for example, a traditional primary care setting. And we see long COVID all day.
Mm-hmm.
This is by far one of the most common conditions that we are supporting people with. And because long COVID, many experts believe that long COVID is not itself a unique thing. Long COVID is something else kicked off by COVID. And so when we think about any number of post-infectious chronic conditions, those things have some known things that help. So what we've learned is that by applying what is known about the other post-infectious chronic conditions to supporting people with long COVID, is that we're helping people feel better.
I've definitely started to notice that the increased recognition in talking about long COVID, the increased recognition of a lot of these types of chronic inflammatory post-infection or whatever it might be conditions, PTSD falling in that, and fibromyalgia, as well as a lot of those other things, that people are starting to recognize it, and maybe my hope is research it more with long COVID.
Yeah, and I think that the narrative out there from the traditional healthcare system is that patients are actually being told, quote, "there's nothing to do for you." And that's just wrong. There is something to do for you. We're doing it all day. It's just about you, if you're waiting for, randomized controlled trials of following blood clots just like it's this is not new. It's just you have to shift the paradigm, I think, and that's what's really, really missing. But I think the idea of just like, we need more research. Well, we don't know yet. Sit tight. There's gonna be, this magic bullet. It just that's really unhelpful for people. I think that it's about, what do we know? What can we learn from that? What are some benign, even over-the-counter medicines and supplements that are worth considering, whether this in fact might support your mast cell dysfunction, et cetera. The other thing that I think is really worth considering is that some of the standard treatments for some parts of this cluster make the other parts of this cluster worse. So in a world where much of healthcare is fragmented by body parts or organ systems, that misses the opportunity to notice those internal conflicting access needs. Example, if someone with POTS, positional orthostatic tachycardia syndrome, POTS/dysautonomia, one of the standard things to do is to offer compression. Let's say, for example, compression stockings. Well, if this person also has a hypermobility spectrum condition and they have extra stretchy or compressible blood vessels, well, when the compression is too tight, you cut off their blood flow, and then it hurts more. So or for example, someone with chronic pain might be prescribed a muscle relaxant, but if they have hypermobility spectrum, like stretchy connective tissue, and their extra floppy, stretchy connective tissue is now collapsing on itself when they sleep at night and making their unrecognized sleep apnea worse, which makes their fibromyalgia worse, their pain worse, their dysautonomia worse, their thinking worse, all of it. And it all started from a medicine that was a standard, seemingly benign thing to do.
Mm. So could you speak a little bit, you touched on the connective tissue portion of this quite a bit, and as certainly as a structural integrator who thinks about fascia a lot, but also understands that it's way under-researched and understood. What's your understanding of what's going on? What is the connective tissue relationship to this cluster?
Yeah, I think that, if we look at, for example, within the hypermobility spectrum, which might include joint hypermobility, and depending on, how significant that joint hypermobility is, someone might get a diagnosis, for example, of hypermobile Ehlers-Danlos. But joint hypermobility is, I think only one part of the hypermobility spectrum. So it's thought that autonomic nervous system differences, dysautonomia, mast cell dysfunction, the autoimmune hypersensitivities, tissue hyperextensibility, all of this fits into that umbrella. I'm curious for you, based on what you're seeing, if you're thinking about how the autonomic nervous system dysregulation has an impact on connective tissue. Like, in my mind, those things are connected. But is that what you're seeing?
I'm now that you're mentioning it, I'm beginning to observe a pattern. I'm not sure I have enough data sets that I've thought about, at least, to draw any conclusions at this point. But they're definitely, and I feel like lately I've been seeing people with a specific type of hypermobility that I wasn't seeing before, and I don't know if it's that I wasn't paying attention to it, honestly, or that there has been some sort of increase, that there is, it's not just the tendons and ligaments, and it's not like, the confusing part is someone can have a really tight shoulder and have areas in their body that are hypomobile, that are not, but that might be a muscular holding pattern.
Exactly. And I think what happens for a lot of people who don't present as stereotypically hypermobile, they don't look like Gumby, they present to professionals who are missing that, they're missing hypermobility. And if something's tight, there's not necessarily a thinking about what function that tightness serves. So a lot of times what we see is that someone will go work with a professional who releases something that was tight, and then that night everything clamps down and they're so much worse. And sometimes, they actually end up in the emergency department because they're in so much worse pain because it was not identified that tightness was actually keeping their cervical spine stable, for example.
And it's interesting because my work, I consider myself primarily a space maker, not a tightener, historically as a structural integrator. Now as an OT, when I'm thinking a little bit more in terms of exercises and functional activities, that starts to tighten up and coordinate things. Historically, the biggest problems I've had have been the sort of classic hyper flexible person who is like the yoga teacher, who's not only hyper flexible but is actively moving towards flexibility, and then they end up having like those couple of areas that are just not in their awareness that are just clamped down. I release those, and if I don't release those in sequence and support them, then they're much more prone to injury. And it's sort of, because I systematically release things, the idea is I'm visiting all the tissues, not just saying, oh, you got some tight shoulders here, and then just releasing those shoulders.
Right, because you're seeing the whole of the person. And I think that's really important. And I think that in a traditional healthcare system, I think the system itself interferes with professionals having the the time, the bandwidth to really be often to be zooming out far enough to see the big picture. And I think another piece of this is that you can find the perfect combination of medicine, supplements, physical therapy, body work, energy work, like all the things. And then the person goes back to their environment that is driving the cycle. So for example, let's say somebody's, they put together their dream team, including you, and they're getting better, but then they go to their terrible job where they are, othered and traumatized and given the narrative that there's something broken about them. Well, guess what? I think that's going to actually be an impairment to getting better, because a lot of these, it's interesting that you're saying you're seeing more of this. I think that this in many ways is like the canary in the coal mine of the neuroimmune, like unsafe, pay attention to me. And if you don't pay attention to me, and I'm going to keep trying to get your attention, that this is not working.
Yeah, and I've definitely seen the neural overload that you're talking about. It's it coming up in the fascia in a different way, coming up in the tissue in a different way. Do you have a sense of what that mechanism is that is causing these types of overloaded systems, these types of traumas? Or I really like that there's now the complex PTSD discussion as opposed to a single traumatic event that fits into movies quite well.
Right. And I think I'm reaching for a book. One of my favorite books is this book called Sensory Trauma. So the subtitle, Autism, Sensory Difference, and the Daily Experience of Fear. It talks about how, in addition to the traumatic events, as you said, these macro traumas, the chronic micro traumas of everyday life, in living in a world that's not designed for your access needs, that itself causes the same tissue, cellular, genetic changes. And so my wondering about what connects all of this is a type of immune cell called the mast cell. For example, there is literature linking mast cell dysfunction to PTSD. Mast cells and fibromyalgia, mast cells and migraine, mast cells and Crohn's disease, mast cells and so in a bubble, we know that mast cells are related. Mast cells being the often the first line of defense of environmental trigger, say pollen, unsafe, releases histamine, leukotrienes, norepinephrine, all these different signals to recruit more immune cells to rally. And if it is either that there is something in the environment that's unsafe, those mast cells may be releasing either they may be reacting to something that's, not objectively unsafe, or reacting in a way that is disproportionate to the threat. So I get stung by a bee, unsafe. I need my mast cells to respond. I maybe don't need my entire body to swell up with hives. That maybe is unhelpful. So that's a disproportionate response. And we see a lot of this. And so just a general trend that we have seen is that mast cell targeted medicines and supplements, many patients have found that helpful who have this cluster.
So I guess and I tend to view things from a evolutionary benefit standpoint. What I'm trying to think, what in the body, being under these types of stresses, why would we be triggering a laxity in our connective tissue? What's the mechanism where, under what circumstances is that a good thing? That these types of stresses could lead to that, or is it really just further downstream and I need to step out of my more functional evolutionary paradigm?
I think the paradigm, and is an interesting one. I think the question is an interesting one. I think that and I can try on any number of ideas about that, but I think back to my canary in the coal mine situation, it may not be that the downstream consequence of laxity is like an evolutionary benefit. It may be that it's getting your attention, that pain, dysautonomia, all of this is a way of like, pay attention. This environment is not good. And if we continue to have environments like these, bad things are going to happen. And I think we're seeing that with long COVID.
Okay. I was listening to I can't remember who it was, but there was an interview with a woman talking about loneliness, and just the act of feeling lonely will actually increase your inflammatory response and decrease your ability to fight viruses. So of course that hand in hand with social isolation and loneliness with COVID was very problematic. People feel more lonely and they're actually less able to fight off viruses. And it was just interesting to think about that inflammatory response, that if you're not, that things could be hyper inflamed.
Yes.
And I think that some of my question is just that fascia is such an under-researched tissue, this connective tissue, when you're laying down collagen fiber and what density and what orientation, and how it's interacting with the nervous system is such a budding field of understanding that I had the feeling that we'll have a better understanding as these are converging, the understanding of these chronic conditions in constellations and the physiology of how fascia actually functions. And I hope
is it possible that the fascia is tightening or moving or not moving? Is the fascia trying to protect the body when there's inflammation in the region? Is that possible?
That would intuitively make sense to me. The piece that's throwing me off is the fact that fascia would become more lax, and I think a protective. I would imagine that these people, if I didn't have you explaining this to me and wasn't starting to observe this, I'd imagine these people would just have more scar tissue and more restrictions in their fascia overall with these more stress, not less. But maybe that's a hormonal response to the fact that if you're under stress, then you're probably developing scar tissue. So so let's counteract that, and the body is counteracting by releasing hormones that are actually relaxing the fascia overall to make so that you're not impaired. I'm of course just hypothesis all over the place. So that maybe it's the body actually trying to counterpoint the likely physical trauma historically that people would go through. That's
very interesting.
If everything's scarred up, then we got to loosen something so you can continue to move. But now with the more emotional and environmental trauma that isn't resulting in mass amounts of scar tissue all the time, that people are becoming hypermobile.
But I mean, is it possible that they may have like joint laxity, like ligament laxity, but their fascia is still restricted?
I guess when I say fascia, I tend to use the broader category that includes ligament and tendon along with it.
Oh, okay.
And
I was
so
imagining the
yes,
surrounding soft tissue that's like,
yeah, and that might be something to explore, but feel like those tissues, they're all really sort of the same tissues when you look at them. It's a matter of orientation and location, but maybe they receive hormones differently because they have
that's
different blood flows, so that you'd have a difference. That would be one of the main differences between intermuscular fascia and tendon, would be amount of blood flow and hormone response. So maybe that's why we're getting an asymmetry.
That is
in
so
the two.
interesting. That is so interesting. And if you think about blood flow obstruction, like so for example, a lot of people in the All Brains Belong village have thoracic outlet obstruction. And a lot of them, they have restriction down below that it's impacting their ability to breathe. So they're using accessory muscles in their neck to breathe instead of using their diaphragm. They also maybe have some like motor planning issues that result in ineffective breathing patterns. Anyway, either way, muscles in the neck super tight, obstructing nerves, arteries, veins in the neck, and a lot of pain patterns are related to that too. And so that what you just said made me think about how blood flow can be obstructed structurally, in addition to hormonally. And we know that, for example, mast cells are responsive to hormone shifts, and so it could become a vicious cycle, I think.
I tend to save the more in-depth, more like collegial type conversation that we've
Yeah.
had towards later in the sort of post-interview conversation. But I'm glad we've had this. To sort of bring it a little bit back to the guests, under what circumstances might someone seek out All Brains Belong, who might not think that they might be a good candidate for it, but should consider it?
Yeah, I think that, All Brains Belong can provide serve a number of different roles for different people. I think people reach out because they are, they're feeling isolated. They're feeling like they are, not connected with community. And so this might be, whether through receiving direct medical care or not, because our community programs, which by the way, all our community social connection programs are free, and they are open to anyone, even people who get their healthcare elsewhere. So I think it's just a matter of either for themselves or their family members, looking to learn more about brain science and the brain science of mental health, and the impact of relationships. I think it's we want to be offering something that is helping people form social connections. That's the point of the community programs. And I think for people, when we bring people together, a lot of times many people are feeling safe for the first time. We really want to be creating an environment where people can show up as their authentic, true selves. So I think that that the people who maybe, for example, last night at Brain Club, people were sharing that they maybe have a hard time even knowing what their true self is, because they, in general, have to mask or cover up, their own access needs, their own interpersonal access needs. So, we're really trying to, and right now, most of our programs are virtual. So, and when the weather gets warmer again, we'll resume outdoor activities. Really, we're providing a COVID safe way of connecting with other people. That's the point.
Okay. And that'll be evolving as the outdoors and COVID stuff changes or evolves.
Yeah, for sure. Yeah. And from the healthcare side, I think people come here because their needs are not being met in other traditional healthcare settings. We are creating a space where people, above all, they're listened to. And maybe in so doing, they end up acquiring a lens that might be a fit for them as far as whether this hypermobility spectrum applies to them.
Mm-hmm.
And maybe that becomes then a path forward. But I think our programs here are informed and driven by community need. We have a community advisory board that that is the basis for anything we do here. And so I think that being outside of the traditional healthcare system, we're small enough to be flexible and responsive to the needs of our patient community. And so, patients are regularly giving feedback, and we're creating new programs all the time and adapting things to make sure that we're really optimizing the experience of the people who are in our village.
Mm-hmm. And is this Montpelier based, or where are you located?
Yeah, we're in Montpelier. I think that, they people who are, they have local primary care. Let's say they live pretty far from Montpelier, but they live elsewhere in Vermont. But they have local primary care, but they need some additional support for brain, nervous system, connective tissue health. They might get most of their care here virtually, and that's okay.
Mm-hmm. And then what insurances are accepted?
Yeah, we accept Medicaid, Medicare, Blue Cross Blue Shield of Vermont, Cigna, and MVP.
Okay. And you do primary care as well as filling those specific needs for people who have other primary care?
That's right. We do primary care for neurodivergent patients.
Mm-hmm.
Plus the conditions we've talked about. Plus, we do gender affirming hormone treatment. There's a relationship between neurodiversity and diversity of gender and sexuality, and so this is feedback from our community advisory board is that to be able to provide enhanced access for gender affirming medical care, that was something we did pretty early on, was create a track for that.
Okay. That's great. Thank you so much for coming on today. I feel like we've covered so much great material, and I look forward to future conversations with you.
Absolutely. Thank you so much.
Thank you for listening to Resilience Radio. If you enjoyed that episode and want to keep up with what we're up to here at Resilience Occupational Therapy, you can like our Facebook page, facebook.com/resilienceot, and get up inspirational quotes as well as up-to-date podcasts and other happenings, videos, and other such things. Thank you to Aaron Marcus for providing the music for this show with their tune Some Biological Process. You can check out the show notes for full credits on that. You've been listening to Resilience Radio. Take care.